Hello. Am I audible to everyone? All the people on the Zoom, please give a thumbs up. Okay, okay. So there are 5 people. Okay, you can ask question in between and I will take the questions whenever I feel like. So now let's start this. This is a very good question. A patient presented with palpitation, headache, presented with palpitation. Palpitation means heart rate is increased. There is headache and diaphoresis, that is sweating. So whenever you see these three things, that is called as PhD, that is palpitation, headache and diaphoresis. So what is this triad? This is a triad of pheochromocytoma. So the thing आपके दिमाग में तुरंत आने लगता है भाई this is pheochromocytoma. Whenever there is palpitation, headache, diaphoresis, you start thinking of the pheochromocytoma. But this is what you have to understand. You have to keep a control on your nerves. That if just by looking at something, don't go to the diagnosis. Now, second thing is, if you see physical finding, what are the physical findings? Saying that pulse rate is blood pressure is this is blood pressure is 160 by 110 and heart rate is 110. That is, there is increased heart rate, there is increased pressure. Now you are confirmed that no, this is the diagnosis of pheochromocytoma, but it is not so, because you have to look to the other situations, because there are a lot of situations which can mimic like this. So yes, the triad of pheochromocytoma is P, that is palpitation, H is for headache, and D is for diaphoresis, that is sweating. On the physical finding, you will find sinus tachycardia, that is heart rate is increased, and increased blood pressure. Now, in this patient, what the TSH is 0.2, which is less than the normal, which is pointing towards hyperthyroidism, because in hyperthyroidism, TSH is low, and in hypothyroidism, TSH is high. And free T4 is normal. That means this is a case of subclinical hyperthyroidism, because in subclinical hyperthyroidism, what happened is T4, T3 is normal, but TSH is decreased, and there is no symptom to the patient. But please remember, patient is at a risk of development of the cardiovascular things like atrial fibrillation, and there are chances that in subclinical hyperthyroidism, pregnant women are very much at a high risk of development of uh, hypertension and cardiovascular disease. So it is a subclinical hyperthyroidism. So we are not knowing that whether it is pheochromocytoma or not, but yes, one thing that is confirmed is it is subclinical hyperthyroidism. Now, second is plasma metanephrine is more than 3 times the upper limit. Now, we'll read whenever this is whenever the metanephrines are more than 3 times the normal. What do you think? You think always think of the pheochromocytoma. So the symptoms, that is PhD, the physical finding, that is heart rate increased and blood pressure, plus the laboratory finding are very much taking you towards the what? Pheochromocytoma. Now, when you do the CT scan, you see a 9.7 centimeter right atrial mass. Now you are confirmed it is pheochromocytoma. You are ready to kill someone if he says that no, it is not pheochromocytoma. And the attenuation is less than 10 Hounsfield unit. Now this is the catching point. And there is loss of intensity on MRI on diagnosis. So what is the diagnosis? So this is a very now, before understanding what is a diagnosis, we have to, and please remember, it is not pheochromocytoma. And they are asking, what is the likely diagnosis? What is the diagnosis? It is not pheochromocytoma. I am telling you why. But before understanding that, let's dive detail. First, understand what is pheochromocytoma. That is, what is pheochromocytoma? We know that there are we have adrenal medulla. In adrenal medulla, we have chromaffin cells, and these chromaffin cells can secrete what they uh, can go into malignant transformation and can form what tumor, that is called as pheochromocytoma. But please remember, these chromaffin cells in the adrenal medulla are present, but they are also present in extra adrenal site. For example, if you see aorta, in the aorta, where the aorta bifurcate, there is a very special accumulation of chromaffin cells, just like the chromaffin cells of the adrenal medulla, and they are called as organ of Zuckerkandl. They are called as organ of Zuckerkandl. So they are also a pheochromocytoma, but they are what? They are extra abdominal, or you can say extra adrenal pheochromocytoma. They are extra adrenal pheochromocytoma. They have some special property that we will discuss after some times. So these are this is extramedullary, extra abdominal pheochromocytoma are also possible. For example, organ of Zuckerkandl. Now, where are, so they ask you where is organ of Zuckerkandl? Organ of Zuckerkandl are the chromaffin cells present at the bifurcation of the uh, abdominal aorta of the aorta and close to the which artery? This is also asked. So they are close to the inferior mesenteric artery. They are close to the inferior mesenteric artery. Inferior mesenteric. This is also asked. Mesenteric artery. So organ of Zuckerkandl is basically chromaffin cells which are present at the bifurcation of the aorta close to the inferior mesenteric artery. And if they develops, now what are their functions? In the case of the neonates and in the fetus, they produce adrenaline, just like the adrenal medulla does in the adults. So since adrenal medulla is not well developed, so they produce adrenaline, and once the person baby is delivered, they slowly regress. But sometimes they can form tumor and undergo malignant transformation, which can form pheochromocytoma. So that will be called as extra adrenal pheochromocytoma, or they are called as the uh, tumor of organ of Zuckerkandl. And please remember, they will produce what? They will produce the uh, your noradrenaline, norepinephrine. That we will understand. Now, so we have understand that adrenal medulla mein there are chromaffin cells, and these chromaffin cells can produce what? These can produce dopamine. They can produce dopamine. They can produce norepinephrine, and they can produce epinephrine. So this is called as pheochromocytoma. And if it is extramedullary or extra-abdomen like organ of Zuckerkandl, they can also produce it. Now, we have to understand a very important thing here. Now we have phenylamine. Phenylamine forms tyrosine. Tyrosine forms L-dopa. L-dopa forms dopamine. Dopamine forms norepinephrine, and norepinephrine forms epinephrine. We have to understand this because this simple thing will help us to know a lot of things. Now, so starting point is phenylamine. Second is tyrosine. Tyrosine will forms L-dopa. L-dopa will forms dopamine, and dopamine will form norepinephrine, and norepinephrine will form epinephrine. So whatever the three constituents are circled with the red, pheochromocytoma can secrete them. That is epinephrine, it can secrete epinephrine, it can secrete norepinephrine, it can secrete dopamine. So if someone asks you what are the things which pheochromocytoma secretes, so answer will be dopamine, it can also secrete norepinephrine, it can also secrete epinephrine. So this is what it is written here, that they secrete dopamine, norepinephrine and epinephrine. Now there is a very important catching point. There can be pheochromocytomas which can produce all of these three, that is epinephrine, norepinephrine and dopamine. But there can be pheochromocytomas which can just produce dopamine. Okay, they will all only produce dopamine. Then there can be pheochromocytoma which will only produce norepinephrine. Norepinephrine. So you will ask me what is the fun in explaining these things, that there is no pheochromocytoma which will produce only epinephrine. No pheochromocytoma which will only produce epinephrine. Okay, so they can produce epinephrine, norepinephrine and dopamine. They can produce only dopamine. They can produce only norepinephrine, but there is no pheochromocytoma which will produce only epinephrine. This is what you have to understand. Now, this is just factual things, but there is a reason behind each and everything that we will discuss. Okay. Now, so we have understand that pheochromocytoma can produce three things. What are they? These are norepinephrine, these are epinephrine, and these are dopamine. But we have to also understand what is the final fate of these things. So, norepinephrine will lead to the formation of normetanephrine, Normetanephrine. Epinephrine will form metanephrine, and dopamine will form 3-methoxytyramine. 3-methoxytyramine. This is very important. Okay. So norepinephrine will form what? That will form a normetanephrine, epinephrine will form the metanephrine, and dopamine will form the methoxytyramine. This you have to understand. Now, this is the basic thing that you have understood. And you will be thinking that this is very difficult to understand, remember. No. Now, I will tell you the exact reasons. Now, the questions that we have discussed, there are four options that are given and that we will deal after some time. Now, first coming to the pheochromocytoma, which is the tumor of chromaffin cells, which are present in the adrenal medulla or may be present outside the adrenal medulla, example, organ of Zuckerkandl. And they can secrete what are the three things? Epinephrine, norepinephrine, and dopamine. Now, the coming to the symptoms. The symptom is PHD, the pheochromocytoma symptom, which has been mentioned in the uh, our question is PHD. P is for palpitation, H is for headache, D is for diaphoresis. And whenever this three triad is present, we always think of pheochromocytoma. Please remember, there H is for headache, not for hypertension, because in the options you will be also provided hypertension and you will be confused. Please note that these PHDs the symptoms, not the sign. Hypertension is a sign that you will get as a doctor when the patient will be presented to you. When you will examine the patient, you will see sinus tachycardia and hypertension. So the clinical triad does not consist of the physical sign. It consists of the symptom, that is PHD, that is palpitation, headache, and diaphoresis. And the physical finding that you will get after examining the patient is heart rate of more than 100, that is sinus tachycardia, and then you will also get high BP. And whenever these things are present, that is a clinical triad, along with these two physical finding, you have to think of the pheochromocytoma. I have said you have to think. You don't have to make the diagnosis. Now, in this patient, you know that TSH is decreased. That means patient has what? Patient has hyperthyroidism, and T4 is normal. But here the patient, so this is a condition which is called as what? This is called as subclinical hyperthyroidism. This is a situation which is known as subclinical hyperthyroidism. So one thing that is confirmed in this patient is that this patient is suffering from subclinical hyperthyroidism. Now coming to the a very important question that is asked a lot of time. What is the clinical triad of pheochromocytoma? Now we have just read PHD, that is P for palpitation, H for headache, not hypertension, and D is for diaphoresis. So this is selling hyperventilation, no. Headache, chest pain, no. Palpitation, dizziness, no. Palpitation, PHD, that is PhD. So answer is D, palpitation, diaphoresis, and the headache. Please remember, sometimes they will also confuse you by giving in the symptoms hypertension. Okay. Now, this is a very important thing that you have to understand. Now, we have just read here. Please see what we have seen. We have seen that phenylamine will form tyrosine, tyrosine will form L-dopa, L-dopa will form dopamine, dopamine will form norepinephrine, and norepinephrine will form epinephrine. So we have to understand this part, that is formation of epinephrine from the norepinephrine. This part we have to see. So what is important? Let's see. No. So now this is norepinephrine and this is epinephrine. Now, what you are seeing in this two very important thing is there is an enzyme that is PNMT. What is the name of this enzyme? PNMT. It is phenylethanolamine N-methyl transferase. So understand it. Basic function of this enzyme is to transfer a methyl to the norepinephrine. The difference between a norepinephrine and epinephrine is the structural difference. That is what here you see. This is the NH2 group, and here there is a methyl associated to the NH2 group. So whenever the NH2 group of the norepinephrine has a methyl group attached to it, it becomes norepinephrine. It becomes epinephrine. So they can also ask you, or they have already asked you in biochemistry, epinephrine is the methylated product of the norepinephrine. So when the enzyme PNMT do methylation of the norepinephrine, it leads to the formation of the epinephrine. Okay, so just a difference of a methyl group leads to a lot of change in the functions of these two compound. Okay, now very important compound, very important thing. Now, then these norepinephrine and epinephrine are acted upon by an enzyme that is COMT, that is catecholamine O methyl transferase. They also transfer methyl. Now, how they will transfer methyl? You see, there are two OH group attached to the norepinephrine and also two OH group which are attached to the epinephrine. Now, very important. In pheochromocytoma, whenever we do laboratory diagnosis, what we do is we always uh, measures normetanephrines or we measures metanephrine. We never measures norepinephrine or epinephrine. Why? This can be a question that can be asked. The answer lies here in these two OH group. These two OH group which are present adjacent to each other in norepinephrine and epinephrine, they make this compound very much reactive. So even sunlight, even oxygen, they all can destroy it. That is why you see whenever if you see in the ICUs, if you see norepinephrine or the epinephrine, you will see that the vial in which they are present, the ampules in which they are present, they are of dark colored because even the sunlight can destroy them, can deactivate them. So why? So if you ask someone that why the ampule is of dark brown color, the reason is to prevent it from the sunlight. But why to prevent it sunlight? Because of the this two OH group makes them highly unstable, highly reactive. That is the reason they are not measured. Because when they are highly reactive, their half life is very low, so you cannot measure them. Now, second is normetanephrines and metanephrines. When COMT enzyme, that is catecholamines O-methyl transferase, transfers a methyl group to one of this OH group. See this OH group, the OH group is removed and instead a methyl group is placed. Similarly, in case of the metanephrine. So now the reactivity of epinephrine and norepinephrine decreases, and what happens that their half life increases, so they can be measured. Therefore, this is the reason why in pheochromocytoma you don't measure norepinephrine or epinephrine. Instead, you measure normetanephrines and metanephrines, which are the degraded products of them by the enzyme COMT. Now, second reason why we don't measure epinephrine and norepinephrine is that norepinephrine and epinephrine are released into the body during fight, flight, or stress. Whereas so there can be a chance that while you have taken the blood of the patient is relaxed, there is no fight or flight like situation, and the blood can give you a normal norepinephrine or normal epinephrine. That is why they are also not measured because they are episodically they are released, whereas the normetanephrines and the metanephrines, they are always they are leaky products and they are always leaked out. So whenever there is more norepinephrine, there will be more formations of the normetanephrines and metanephrines from them, and since they are leaky, they are always released, so you can measure them. So if I ask you what are the two reasons why these are measured, the first is epinephrine, norepinephrine, because of two OH groups are highly unstable, therefore they are not measured because their half-life decreases. And the second reason is that metanephrines and normetanephrines are always produced in a leaky manner. So these are the two things. Then then there is enzyme that is SULT1A3. SULT1A3 that acts on the normetanephrines and convert normetanephrine into the normetanephrine sulfates and metanephrine into metanephrine sulfates. They are of not much use. But if someone asks you what does total metanephrine means, then if someone asks you what is total metanephrine and why we don't measure, because total metanephrine consists of the normetanephrines and metanephrines plus their sulfated compound. Okay, so it becomes very cumbersome to measure them. So sulfated conjugated metanephrines are not measured. What is measured is only these normetanephrines and metanephrines, which are known as free metanephrine. So this was regarding why some compounds are measured, some compounds are not measured. Okay. Now, one thing that I want to explain you, that you have just seen a very important enzyme, that is PNMT. PNM, that is what? What is PNMT? PNMT is the phenylethylamine and methyl transferase. What it does, it converts the norepinephrine into the epinephrine. So how it does it? It just give a methyl group to the NH2 of the norepinephrine. Now, if in certain place this PNMT enzyme is absent, then what will happen? There will be no epinephrine. There will be no epinephrine, and there will be only production of norepinephrine and its degrading product, that is normetanephrine. So in that patient, you will not find epinephrines and metanephrines. So if anywhere where the PNMT enzyme, that is phenylethylamine and methyl transferase, is absent, you will not find epinephrine and metanephrines. That is what I was initially telling you, that there are certain pheochromocytomas which does not produces epinephrine. So pheochromocytoma which will be not be producing epinephrine, be happening in them? They will be absence of PNMT enzyme in them. This is the first thing that you have to understand, concept, that all those pheochromocytoma in which there will be no epinephrine or its degraded product metanephrines, there will be absence of this enzyme PNMT. And what are those pheochromocytomas? These are the pheochromocytomas which are extra adrenal, especially extra abdomen, especially in organ of Zuckerkandl. So these are three things that you have to understand. First, organ of Zuckerkandl or extra adrenal pheochromocytomas does not have enzyme PNMT. And since they don't have enzyme PNMT, they don't form epinephrine or its degraded products metanephrine. Therefore, during their laboratory finding, we will find just increased normetanephrine. This is the carry home message that you have to understand, because a lot of questions can be asked and have been asked in the travel way in this and can be asked afterwards. Now, someone can ask you question, why in adrenal medulla we have this enzyme PNMT, but if we talk of the organ of Zuckerkandl or extraadrenal tumor, there is no PNMT, because this PNMT enzyme requires cortisol. If cortisol is present, then only this enzyme can be formed. And we all know that adrenal medulla is highly prone to and highly subjected to increased cortisol levels. Therefore, it has this PNMT enzyme and thus formation of the epinephrine, whereas organ of Zuckerkandl are not exposed to the high level of the cortisol. Therefore, there is no PNMT enzymes and thus no epinephrine. Now, this is a very important question that has been asked. There is a 45-year-old male patient with episodic hypertension, palpitation, and headache. Laboratory studies reveal elevated plasma norepinephrine but normal epinephrine. We have just discussed. What is there? That there is a normal, what happened? There is a normal elevated norepinephrine but a normal epinephrine. That means which enzyme is absent? The enzyme absent is what? Phenylethylamine and methyl transferase. N methyl transferase. This enzyme is absent. And where this enzyme is absent? Generally in the organ of the Zuckerkandl. So in organ of Zuckerkandl. So what is they asking? Which of the following best explain the absence of epinephrine? So why? So that this you can very well understand, that because there is absence of enzyme phenylethylamine and methyl transferase, there is no epinephrine. And if you do the laboratory diagnosis of this patient, what you will find? You will also find that there will be no metanephrine in the blood. So this is very important point. Now, Very important thing is regarding the sample collection. Now, I have told you when we do the laboratory diagnosis, here just see this. Whenever we do the laboratory diagnosis, we understand three things. That pheochromocytoma can produce what? Um, they can produce epinephrine, E is for epinephrine, N is for norepinephrine, and dopamine. Now, epinephrine will form what? It will form metanephrine, and norepinephrine will form normetanephrine, and dopamine will form, yes, please remember this, dopamine will form 3-methoxytyramine. So I have told you there can be pheochromocytoma which will be secreting all the three. There can be pheochromocytoma which will be secreting only dopamine. There can be pheochromocytoma which will be secreting norepinephrine, but there is no pheochromocytoma which just secrete epinephrine. And and which pheochromocytoma only secrete norepinephrine, which does not have, which have no PMNT, that is phenylethylamine and methyl transferase, PNMT. Okay, and where are they present? They are present extra-adrenal. Now there are certain. So what we do? We do the measurement of these three laboratory markers. No, but there are certain catch in their measurement. Please remember, if so first we'll see. Now, if someone asks you there is a pheochromocytoma who is in has been diagnosed and the laboratory findings show normal normetanephrine and increased 3-methoxytyramine, then what you will tell? That means that pheochromocytoma is a dopamine secreting pheochromocytoma. So one more concept came here that dopamine secreting pheochromocytoma will have an increased 3-methoxytyramine and a normal metanephrine and a normal normetanephrine. This is the one of the carry home message and has been asked several times. Now, very important point is regarding the sample collection. How to do the sample collection? Regarding the sample collection of these things. Now, metanephrines, please remember what metanephrines are found from what? Metanephrines or normetanephrines are found from the epinephrine and norepinephrines. And for example, if I sit down or if I stand, my blood pressure will fall and body will try to increase the blood pressure. So there will be sympathetic overstimulation and more epinephrine and norepinephrine will be formed. So there will be more metanephrines and normetanephrines will be formed. So if at that time I will take the blood sample of the patient, what I will find? I will find a false positive result of the metanephrines and the normetanephrine. Therefore, it is always advised that the patient should be in the supine for 20 more minutes before the sampling. This is very important to understand. This can be asked, and you have to understand that why the patient should be in the supine position for more than 20 minutes before sampling, because if the patient is sitting or the standing, we have a false positive value. We can have false positive value because of the overstimulation of the sympathetic system. Now, simply stress, caffeine, nicotine, these things increases the sympathetic stimulation. If you drink coffee, if you drink chai, that is tea, and if you are in stress, sympathetic stimulation will be there. And when there will be sympathetic stimulation, more epinephrine and norepinephrine will be formed. And what will happen? So more norepinephrine and metanephrine. Therefore, it is advised that patient should not take coffee or should not be in the stress. For example, a patient is under stress, admitted to your ward, and you have just taken the blood sample and have sent it for the metanephrines. So you are doomed to have a false positive value because patient was under stress. There was overstimulation. And what you will see there will be increase. A lot of time, please remember, one patient, heart failure patient was admitted in our ward and there was also hypertension. So one of them, our doctor senior said that this may be a case of pheochromocytoma because a lot of thing was pointing towards that we will not discuss here because that will further elongate the discussion. So we sent metanephrine. It came 4 times. So what was the reason? But finally, it was found after CT scan and MRI that patient was not having pheochromocytoma. So what was the reason that pheochromocytoma was so that metanephrines were so increase. The reason was patient was under the stress. There was overstimulation. There was sympathetic overstimulation, which was leading to the epinephrine, norepinephrine formation and its metabolite formation. So that is very important under stress, caffeine, and then there are drugs like TCA, tricyclic antidepressant, and levodopa. These drugs can further increase. So if that patient is taking these drugs, you have to stop these drugs at least 48 hours to 72 hours before it. And then the blood is put into the chilled NDTA tube centrifuge. So these are very important point. This is very practical thing, because if you will not do, you have to ask the patient, you have to keep the patient in supine position. You have to ask the patient, you have to keep the patient drug free if the patient is taking antidepressant, levodopa. Plus you should take care that patient should be stress free, no caffeine, no nicotine. Now, very important point. I am telling you for the practical purpose. That is why if you have to make a diagnosis of pheochromocytoma, whenever the patient comes, don't rush just to take its sample. It's a steady, slow process. Allow the patient to settle in the environment of the hospital and then take the blood. Then second is the urinary metanephrines. Urinary metanephrines. Simple is there. Caffeine, chocolate, levodopa should be avoided. Now, there is a very important thing that is the vanilla. Now, please remember, vanilla consists of the vanillin, vanillin, and this vanillin has a structure very much similar to the metanephrines and normetanephrines. Therefore, you can have a false positive result here also. So, if the patient has eaten vanilla ice cream and you are doing its metanephrines level, then there can be also chances. And then the caffeine is similar is the banana. Banana has a lot of compounds which are similar to the metanephrines and the normetanephrines, and it can give false positive. Chocolate and levodopa I have already explained. Therefore, so we have two kind of test. One is the plasma free metanephrines or normetanephrines. So what happens is that plasma free metanephrines level are very much prone to decrease or increase with a slight stress, a slight change of position on the drugs. But the urine metanephrines level, please remember, are not so much prone. Why? Because see, we take 24 hours urine sample, and in cases of the blood, we take just a spot sample of the blood. But in cases of urine metanephrine, we take urine of 24 hours. So what happens is the slight at a sudden change or instantaneous changes are generally ruled out because the urine is collected for a large period of the time, that is 24 hours. So in the nutshell, that is most of the doctors or the endocrinologists say that urine metanephrine over 24 hours is less prone to change on the change of position, change of drugs, change of the eating habit, whereas the plasma free metanephrines is more prone to change. Now, which is more sensitive? A thing which is more prone to change will be more sensitive. So plasma metanephrines are more sensitive, please remember, because a slight change will lead to the change, and urine metanephrines are less sensitive but they are more specific. So still date in endocrinologist there is debate. Some say plasma free metanephrine are the best test, some says urinary metanephrine. But what I have seen in the clinical practice, they order both the test simultaneously. Okay, but for you, if they ask you which is more sensitive, you will say plasma free metanephrine. Which is more specific, use urinary metanephrine. So the first, if they ask you which is the first test to order, you will say plasma free metanephrine. If they ask you which is the most specific or the second test or confirmatory test, you will say urine metanephrine. But in reality, both the tests are ordered simultaneously. Now, if some questions occur after some in some exam that a patient presented with PhD symptoms, and you have do the metanephrines level which has elevated. So what will be your next step? Always the next step will be you have to remove these confounding factors. That is, you have to make sure that the patient was in the supine position for at least 20 minutes. Patient was not in a very much high stress. Patient was not having had coffee or the tea before the test, patient was not having tricyclic antidepressant or levodopa, because a lot of time the new doctors who come, they are very much into making of the diagnosis of pheochromocytoma. So what they do, they just, as the patient arrives, they take a sample and send it and say, oh my god, I've made the diagnosis of pheochromocytoma, and that is not the case. You have to keep, so this slide is very important, keep it in your mind. Now coming to the radiological aspect, very important point. We all know that there is something called as Hounsfield unit. There is something called as the Hounsfield unit. Hounsfield unit. Now HU, now whenever you do a CT scan, you will see on the adrenal gland, you will see a mass in case of pheochromocytoma. Now you have a patient who is having PhD, that is palpitation, H for headache, D for diaphoresis. Then what you see the BP of the patient is raised, heart rate of the patient is raised. What you will do? What you will do in such case? Then you will go for the metanephrines. Metanephrines are increased. Now, just basis on the basis of increased metanephrine, you cannot make a diagnosis of pheochromocytoma. You will also do the radiological finding. Now, if radiological finding, there are very important points that I am telling you. You have to understand. Now, if you see a mass on the adrenal gland, you have to see what is the Hounsfield unit on the CT scan. If the Hounsfield unit is less than 10 HU, if the Hounsfield unit is less than 10 HU, that means the lipid content is very high and it will appear darker. And since in pheochromocytoma there is no lipid or very less lipid, the diagnosis of pheochromocytoma is ruled out. This is very important point. So there may be chances that the metanephrines level that you have done, there must be some confounding factors which I have shown in the previous slide are present. So what you have to do, you have to reorder the metanephrines. Please remember. And in on MRI, there will be no loss of the intensity. So if there is a Hounsfield unit less than 10 HIU, lipid content is that means is more, and this will appear darker, and there is less chances of the pheochromocytoma. On the other hand, if the Hounsfield unit is more than 10 HU, that means very low or no lipid content, and this is highly susceptible to the pheochromocytoma diagnosis. And in this on MRI, what you will see loss of intensity of on MRI. So less than 10 HU, less chances of pheochromocytoma. More than 10 HU, more chance of pheochromocytoma. You can remember like this. Now, if I ask you, and we again come to that initial question that we are having. Now, in this patient, what we are having in CT scan, if you see attenuation is less than 10 HU, which is a high chance that is it is not a pheochromocytoma, because it means it is dark and lipid content is more. So you will ask me, the plasma metanephrine is 3 times the upper limit. That is why I have told you that it may be because of the some confounding factors. The confounding factors, that means patient may be in the stress. As the patient has come, you have sent the blood sample, or the patient may be on the levodopa, although the patient you have not collected a sample in the supine position for after 20 minutes of rest. So there can be a lot of things. And there is loss of intensity on MRI diagnosis. So all these things are taking towards the pheochromocytoma. Now, if I ask you, so what will be the diagnosis in this case? We have already seen that in this case we have already seen that there is a subclinical hyperthyroidism. Because why? Because TSH is low and T4 is normal. That is a case of subclinical hyperthyroidism. So if you see only in the option B, there is subclinical hyperthyroidism. So we can have answer it just on the basis of this. But why it is not a pheochromocytoma? Now, it is adrenal adenoma. Why? Because the Hounsfield unit is less than 10 units. So that means lipid content is very high, and in the adrenal adenoma, lipid content is very high. It appears dark. Now, so answer will be B. Now, a lot of the people will say, okay, so there is a radiologically it is coming to be lipid content, lipid filled content, it is not a pheochromocytoma, but laboratory wise it is coming to the pheochromocytoma. So what should we do? So if in this question, or practically if someone asks you in this condition, you will again send the what? Blood metanephrine and urine 24 hours metanephrine after removing all the confounding factors which I have already discussing. Blood should be taken in the supine position after 20 minutes of rest. No caffeine, no banana, no vanilla, no levodopa, and after that you have to check. And most probably in this case, you will see that metanephrines will be normal value. So this is the thing that, so whenever there is a between, or there is a hustle between the radiological finding which is saying it is not a pheochromocytoma, and laboratory finding which is showing no, it is pheochromocytoma. So practically it is generally, because there are a lot of false positive case in case of pheochromocytoma in laboratory marker. So that means you have to resend the metanephrines, and believe me, in lot of time the metanephrines will come normal and you will diagnose the patient with adrenal adenoma. Now, what will happen if these metanephrines come positive? Then what you will do? Even after removing all the confounding factors, it comes positive. Then what you will do? Then you have to do other test, that is MIBG scan. Iodine 126 MIBG scan. Remember, iodine 131 MIBG is used for the treatment of the pheochromocytoma, and iodine 126 MIBG scan is used for the diagnosis of the pheochromocytoma. It is the golden radiological diagnosis in that case. Okay, so first laboratory marker, if it is positive but radiologically you are not getting it, repeat the biomarkers, and if repeat biomarkers are coming negative, that means it is not pheochromocytoma. If it is again coming positive, go for the MIBG scan, iodine 126, because iodine 135 MIBG is used for the treatment of the. So hope this is a very good question. We will meet again. Thanks.